Hello, my name's Elise Brogan. I'm a GP in Derbyshire at Crouch Medical Practice. I'm also doing a fellowship as part of the GP task force and trying to support GPs who are off. My fellowship's changed a little bit because of the COVID pandemic, and so Gail has very kindly agreed to speak to me so that we can recap a little bit on the things that have changed over the last week. It's the 8th of April today. So, Gail, would you mind introducing yourself?
Hi, I'm Gail Walton. I'm a GP in Ilkeston in Derbyshire. I've been at that practice for 31 years. I also work alongside the LMC and GP task force and have the privilege of actually buddying the GP task force fellows, of which Elise is one, but we've got another 10 and they're all doing amazing things that are completely different from what they envisaged at the start of the fellowships due to COVID, but all doing really relevant, interesting things. So yeah, that's me.
Well, thank you very much, Gail, for giving up some time on this sunny evening to have a chat. We were just going to clarify a few things, because I know there was a little bit of confusion at my practice this week about what guidance there is on examinations at the moment and what we should or shouldn't be doing with patients. Could you speak a little bit about that?
Yeah, I think we talked a little bit about this last week, or perhaps the week before, about ENT and respiratory investigations and examinations. I think sadly since then we know that our ENT secondary care colleagues have suffered greatly, and that's always brings into our minds what we should and shouldn't be doing. Primarily, all the guidance obviously points to clinician safety and keeping ourselves safe and well. And of course, there's been a lot of conversations about the right level of PPE, which I think now there's fairly clear guidance on the LMC website and videos about how to don and doff PPE, because that's so important as well. The pictures on the TV of people occasionally wearing masks sort of around their necks and chins is not good, and we need to be thinking what we're doing and being role models for that within our practices. There isn't any specific guideline about ENT examination, but I think it's generally accepted that people aren't doing throat examinations because potentially that's an aerosol generating procedure. So again, we've got to think about our thresholds for prescribing. If we've got a history that's suggestive of a tonsillitis, for example, needing antibiotics, and maybe our thresholds are different at this moment in time. Respiratory examination, again, the clinician has to be comfortable and confident in what they're doing. I think I've said to you before, Elise, I only will examine backs, and I think you can hear as much listening to somebody's back as listening anteriorly if needs be, but full PPE for all examinations, whether you suspect COVID or not, because I think we've got to assume that everybody is COVID positive.
Yeah, no, I think as you're saying, it's all about trying to keep ourselves safe at the minute so that we can be as effective as possible. The thing that you mentioned about the ENT examination, one GP I was speaking to is getting patients to take selfies. I think that's quite useful then, isn't it? If you are having to bring them down, get them to take a picture before they come so you can have a look. So,
yeah, absolutely. And I think the IT solutions that are coming through in my practice, we've now got, I call it AccuRx, but I think other people call it AccuRx. So ACCU RX has got really quite good video consultation availability. So yeah, absolutely. Patients are only too happy, it seems to me, to be involved in their management, and they're very understanding of the current situation by and large.
Yeah, no, I would agree. And the other thing that we've been talking about as well was CPR. I know you've read
yes. Oh, what a debate about CPR. I as a LMC exec, I'm on a thing called the LMC list server, and a lot of LMC people around the country are backwards and forwards with emails with good guidelines, appropriate advice, asking questions, and actually it underlines that thing. Don't be afraid to ask colleagues and talk to colleagues. So prior to tonight, I just sort of mugged up on what's currently being said, and you're probably as aware of this as I am. So the World Health Organization guidance says that CPR is potentially one of many procedures where aerosol generation is possible.
Yeah.
The national guidance at the moment, and I know the Resuscitation Council are bringing out new guidance imminently, says that chest compressions and defibrillation aren't considered AGPs. So that leaves us in a little bit of a quandary. I will email to you and you can circulate it as you wish. Some quite good facts about resuscitation procedures. It looks at all the most recent guidance. Basically, in a nutshell, it comes back to this thing about the clinician doing a risk assessment and feeling comfortable and confident in what they're doing. So it says that defibrillation, if you got a trace that suggests you should use the defib, that is something that you could be doing whilst other people don full PPE if the decision should be made by a senior clinician after that risk assessment. If a senior clinician feels that CPR is the right thing to do, then other people could be donning full PPE at stage. This refers to a number of small number of systemic reviews, because there haven't been many reviews, but it basically comes down to this thing about it's also an ethical dilemma, as well as considering the success rate anyway of CPR. So I think at this moment in time, we're generally saying it's not something to rush into without full PPR and a good risk assessment by a senior clinician.
Okay, that's really useful, because our practice, we were thinking that you just shouldn't do CPR, but actually it is more of a risk assessment. So I think it's very interesting to me. The other thing that we were talking about was staff testing, because that's just come in this week, hasn't it?
Yeah, staff testing's come in. The full set of guidance about that is on the LMC website. In a nutshell, it says the criteria for testing are testing of a member of staff who's self-isolating because they're displaying symptoms, or testing an adult member. So by adult, they mean over 18, an adult member of a staff member's family who are self-isolating because of symptoms. The test should be done within 4 days of symptoms, because the antigen testing is only valid for 5 days. Appointments can be booked. There's an online form to fill in. Again, it's on the LMC website, but practice managers, I was in on their webinar this morning, and they're fully aware of how to do that. So testing is available. Logically, in my mind, I suppose it's going to be more use in that family member testing, because if mum or dad are the healthcare worker and are completely well, it potentially gets them back to work a lot more quickly than they otherwise would.
Yeah, I think that is good. It's coming in. You were saying it's in Beeston, isn't it?
It is at the moment, which seems an odd choice for Derbyshire, but that's where it's available at the moment. It's in the car park of the Boots factory, but I know Royal Derby are getting that going fairly soon in a more central Derbyshire location. So
Okay,
able to use.
brilliant.
Mm.
The other thing that's going to be starting at some point are the red hubs. I think, yeah, because I think Derby has one started there, but yeah.
Yeah, so Derby, you'll have probably seen on the news, started their hub on Monday. I think prior to Monday, places have been running red hubs in different ways, but over the course of the weeks, there's obviously been become more sophisticated and more remote in the sense of distancing to keep the surgery spaces safe and as clean as possible. So there will be differences depending on geography and PCN area, but the underlying criteria are going to be the same. So these are hubs where, like we said last week, and stress that we should be seeing a very small proportion of all the patients that we have in telephone and IT contact with. So we should be managing very few patients face to face. But if we do need to see people, so the examples being a febrile child or someone with cellulitis or respiratory symptoms, then they're for the red hub. So, for example, in my area in Erewash this week, the Red Hub model has moved site and the site is purely Red Hub now. Last week, we had one area of the big building as the Red clinic and the rest of the building, which was more isolated as green, but it's now separated. And I think that's the model really beginning across the county.
Yeah, I think ours is being set up in Ripley, so yeah, so we were talking about yeah, we've been asked to kind of volunteer and see how that'll work. Okay, thank you for that. I thought the other thing that's interesting from that is people don't have to definitely have COVID suggestive symptoms, do they? They can have a fever or a respiratory symptom that you think maybe isn't COVID, but that's still the right place for them, is the Red Hub.
It is, yeah.
Great. And finally, was Red visiting. Have you?
Yeah.
Yeah.
So Red Home Visiting Service again has come along this week. The CCG have commissioned this through DHU. I think on Monday they had 2 cars operational. There were 3 yesterday. I think 3 today, with more being rolled out because DHU obviously had to rearrange their rotas and their workforce fairly rapidly to man this. So yeah, the Red Home Visiting Service is in place and working. I've got the guidelines here, and I think the document, the whole specification is available to all GPs to see, and the sort of bullet point highlights are on the LMC website. So this is for people with respiratory symptoms and or a temperature who are likely to be infectious as per current guidelines. They're considered non-infectious if they're at least 7 days from the symptoms. So this is for those with respiratory symptoms and or a temperature that are all housebound would be seen by Red Hub visiting, whether they're in their own home or a care home, and people who obviously need an urgent assessment. The exclusions are people without COVID-19 symptoms, so they should be seen if they are housebound through the normal visiting arrangements for their practice or PCN, or via the green hubs.
Yeah. No, I think, yeah, I haven't had to call the number. It's a number that you call, isn't it? I haven't had to call that yet, but they'll also visit people if they're isolating with someone who has a fever or respiratory symptoms, won't they?
Yeah, yes, they will, yeah.
Have you had to use that number yet?
We haven't. I think there were problems on the very first day for the first few calls, but I think it's working well now.
Great. So yeah, maybe we'll be using it next week. See what happens.
Yeah.
Was there anything else that you wanted to mention, Gail? I think maybe we've covered everything off my list.
I think we've covered everything. Yeah, I mean, the only other thing I think, and it's more about using the all these abbreviations that come along. The new one for this week is CAS, CAS, which is the COVID Clinical Assessment Service, and this is part of 111. So it'll be run by 111, and it's really that telephone triage part of 111, manned now by clinicians. Some of those clinicians are returning GPs, and they may be doing that for areas outside their own. So, for example, I know of one of my Derbyshire retired colleagues who I think is doing CAS actually for the service. So obviously we can remote work and cover any part of the country. So that's CAS, and you may have heard there's been some debate because they should be able to book GP appointments for patients in that cohort 2A that we talked about last week, that need to go back to general practice. And GP Connect is the IT solution, although it's been a bit haphazard in the past. That's going to be the way of CAS getting patients in contact with us. But the advice, and predominantly this really falls to the practice managers, is to make sure those appointments that CAS book into are telephone in the first instance. We don't really want people being booked in face to face. If we can talk to them first, I think we just all need to be clear about taking responsibility for who we're comfortable and confident seeing.
Yeah, I think it's protecting the patients and protecting ourselves as well, isn't it? And I think I said it before, I am finding myself talking and discussing, if possible visit, I'll pretty much always just discuss that and make sure that I'm not visiting unnecessarily, with one of the partners, and it's just making sure that everything is necessary.
Yeah, I think I think as doctors, we're fairly sensitive souls in many ways, aren't we? And I think sometimes we feel that it's like years ago when doing night work, you felt like, should I be going out to this? Do they think I'm lazy if I don't go? But actually, we've just got to take advice, talk to our peers, just benchmark what we're doing. And actually, so much, this is what we're learning from this pandemic, so much doesn't need us to be face to face with our patients in the same room.
Yeah, we don't need to be physically present with everything, do we?
No, and like you were saying earlier, Elise, offline, with patients having good smartphones, good cameras, there's so much we can, if we do need to see somebody, tonsils, rashes, whatever, we've got the technology, and we've got the safeguards of GDPR and such like in place, that we can do a huge amount remotely. So look after ourselves, because if we're not there, the patients don't get looked after either.
No, I think that's very true. Well, thank you very much, Gail. That's been brilliant. It does always make things clearer for me when I speak to you, so thank you. And have a happy Easter, and we can catch up again next week.
Yeah, we'll see how Good Friday and Easter Monday opening works for everybody. But yeah, eat well, not too many Easter eggs, Elise. They are the children's, they're not yours. Okay.
That's what good mums do.
Yeah, some fresh air and vitamin D.
Doing that.
Okay.
Thanks,
Bye.
Bye.
Bye.